This is chapter 6 of the Weber and Kelley textbook. Mental status involves both cognitive functioning and emotional functioning. Mental health, just as the World Health Organization has defined health as more than just the absence of disease, so also mental health is more than just the absence of disease. It's a positive state of well-being where somebody is able to realize her or his abilities, are able to cope with the normal stresses of life, and able to work productively. Remember, Sigmund Freud famously said that mental health is to work and to love. And he was focusing more on romantic relationships, but the World Health Organization focuses more on a person's relationship to the whole community, their ability to make community contributions. Also involved the ability to think clearly and the ability to respond appropriately, and ADL, that's activities of daily living, so effective activities of daily living. A person's mental status is going to be reflected in appearance, both physical grooming, dress, how well they've seemed to be taking care of themselves, in behaviors, in speech, thought patterns, decisions, and ability to function in relationships. So these are all things that will go into the mental health assessment. Some of the factors that influence mental health are economic and social, as well as personal unhealthy lifestyle choices, and exposure to violence, poor decision-making skills, and a low self-concept. Also, poor self-control. And then if you believe in a separate spiritual realm, you would include spiritual factors. Depending on your personal philosophy, some people think that anything spiritual can ultimately be reduced to psychological, social, etc. But other people and many nursing theories, for example, hold that there's a separate spiritual realm, so spiritual factors would be included there. Cultural factors, neurological changes, so you can't have good mental health without good brain health. And psychosocial developmental level. That's remember Erickson and the stages of development, and you can have somebody that is chronologically, meaning their stated age is say 16, but maybe they're not developmentally a 16-year-old. Or you can also have people that are a little bit advanced for their physical age. They're functioning at a higher developmental level. So the basis for defining and diagnosing mental disorders, this isn't a nursing diagnosis, this would be a psychiatric, or maybe psychologists sometimes diagnose mental disorders too. But there's a manual called the DSM-5, it's Diagnostic and Statistical Manual, and it's put out by the American Psychiatric Association, and this is the 5th edition we're talking about. And so it is the basis for making psychiatric diagnoses. Nurses, as I say, well, psychiatric nurse practitioners would probably diagnose these things, but a staff nurse would not diagnose mental disorder, but we need to be aware of them and aware of what goes into a diagnosis of a mental disorder. So this manual says that a mental disorder is first off it's a behavioral or psychological problem or psychological pattern, and it reflects an underlying psychological dysfunction, and it has to cause significant distress or disability. So that is the basis whereby some things have changed over the years, where, for example, there was a time many years ago where homosexuality was considered a mental disorder. And as society changed and as the thinking of psychiatrists changed, why, psychiatrists started to recognize that, well, many homosexuals do experience distress or disability in society, but many others do not. And so therefore they removed that diagnosis from the DSM at that time. Naturally, this caused a lot of controversy where conservatives were saying, oh, it's all political, the psychiatrists are just bending to political pressure. But no, they were not bending to political pressure. They were recognizing that society had changed, that where maybe in the past the majority of homosexuals did experience distress, why, with changes in society, this was no longer the case, and so they were reflecting the changing culture. Another characteristic of a mental disorder is that it's not an expected response to common stressors or losses. So that if you have somebody that is grieving, why, you would not diagnose that person with depression. Now, if the grieving becomes exaggerated and goes on longer than expected and results in suicidal thoughts and that sort of thing, then yes, maybe this is a mental disorder. But the normally expected grieving would not be a mental disorder. And that is going to vary depending on culture, where probably in the US, mainstream North American culture, we don't necessarily grieve as intensely as people like you. If you have patience, if you have an opportunity to see a death, say, with people from other cultures, they may be very expressive of their grief, where your white American, native-born American people are going to be pretty reserved, and if you happen to come from one of those other cultures where it's expected to be more expressive, you might say, oh, they don't even care. So you may grieving and that sort of thing is certainly a culturally determined phenomenon. And the manual was written, of course, by North American psychiatrists who were predominantly white and very much participating in that mainstream culture. So it certainly reflects the biases of people from that culture. And finally, mental disorder cannot be primarily the result of social deviance or conflict. Certainly, there are a lot of mentally ill people in jail. If you ever have an opportunity to visit jail, you'll see that right off. But if a behavior pattern, if a problematic behavior occurs in jail that's primarily just the result of social deviance, conflict, that sort of thing, that would not qualify as a mental disorder. Holistic health tells us that that the whole human being is a complex system, and one part affects the others. So therefore, we would expect that mental disorders can affect the body, and that is indeed the case. And on the converse is also true. Physical disorders may affect the mind, such that if you have somebody that is profoundly depressed, their physical processes may slow. They may end up with constipation. They may they may end up with various other physical manifestations. Similarly, somebody that is in a manic state, their heart rate may be accelerated. So, uh, and also physical disorders can affect the mind. If you, for example, if you uh, have, say, a heart problem, and your heart is weakened, your concentration is going to go down, and you may even see, if your blood pressure gets low, maybe you'll see hallucinations or something like that. Substance abuse is a big topic in mental health, and there are whole hospitals dedicated mainly to just helping people with substance abuse problems. So if you go into mental health, you may actually end up specializing in substance abuse and just dealing with people with substance abuse problems every day. The World Health Organization defines it as harmful or hazardous use of psychoactive substances, including alcohol and illicit drugs. So that covers that. The idea there is that you can have normal use of some substances, and then you would have but for it to have a disorder, it would have to be harmful and hazardous use. And it also mentions that alcohol can certainly be included. A lot of people, a lot of kids, particularly in my generation, our parents had this idea that, well, if the kids are just drinking beer, they're okay because at least they're not doing illegal drugs. And that was, I mean, alcohol is certainly a drug, a substance that can cause a lot of harm. So that was probably some misplaced confidence on the parents' part. One of the things that happens is with some substances, not all, is you get dependence syndrome. So particularly, say, with opiates, with benzodiazepines, with drugs like that, and with alcohol as well. And over time, a person becomes dependent on the substance to feel normal, to function normally. One thing that they may build tolerance, where the liver becomes more efficient at processing it, and so and taking it out of your system, so you need more to achieve the same effect. That's particularly noticeable with opioids, where if you start taking heroin, why, within a matter of weeks, you'll probably develop dependence, you'll develop tolerance, you'll be taking much higher doses than you were at the beginning, and you won't be getting the same effect. But that also happens with things like benzodiazepines, and even with alcohol. It just takes a lot longer for those things to occur. Another thing that happens is you have a strong desire to take that drug, and you'll have difficulty controlling its use. And of course, these things tend to get worse over time, where if you start out and you just maybe you are taking the drug at parties or something like that, and then you just kind of, when one day it's doing it at parties is not enough, one morning you wake up and you think, well, I'm off today and there's no party going on, but hey, I've got some pills here, so let me just take these, and I'll have a good day. And so it does tend to escalate. Same thing can also happen with alcohol, of course, too, where you might be drinking just on weekends, and then suddenly one day you wake up and you think, I'm not going to school today. And I've got all this beer in the refrigerator. Why don't I just have a beer, and start out and having some beer. And that can certainly happen too. Another characteristic of a substance abuse disorder is the need to continue in spite of consequences. So maybe you you were drinking in the daytime and then you failed your class or something like that, and so your parents or someone else intervened and were saying, well, we're going to cut off your support for the university unless you stop drinking. And so you realize, well, yes, this is affecting my studies, but I'm going to continue doing it anyway. It's more important than my studies. And your substance abuse can become your priority in life. Like one patient I had who was addicted to heroin explained it to me. He said, the fix gets you up in the morning because you got to go out and get it. And that, to me, that was a very apt description. I spent a long time with him. I think I took care of him over a period of 2 months. He had an extensive back problem. It wasn't related to his abuse, but I kind of bonded with him, and he taught me a lot about what substance abuse is like from the inside. You may also have avoidance of responsibilities, where that's pretty frequent, where you start calling in sick at your job, or you start making excuses for not doing things that you used to do, or participating in family activities or whatever. And then there's the withdrawal state, which occurs with some substances, particularly, surprisingly, benzodiazepines. Like we think that heroin withdrawal is really tremendous, which it is, but actually benzodiazepine withdrawal in many ways is worse and can be more life-threatening. And this occurs when the withdrawal state occurs when you suddenly cut off the substance, whether it be alcohol in a person that has become alcohol dependent, or heroin, opium in somebody with opiates, or benzodiazepine. And so you don't want to normally, unless the dependence is mild, you would not want to just suddenly cut the person off completely. And that, in the case of alcohol or benzodiazepines, that can be life-threatening. In the case of alcohol, there's a condition called delirium tremens, and for full-blown delirium tremens, there's about a 25% mortality rate. So, and that's the person. It would start with the shakes, getting the shaky ness all over, but then it progresses to hallucinations and a delirium. They get fevers. They get a number of physiological things happen, and so that can be a life-threatening condition, or it is a life-threatening condition. We usually actually treat that with benzodiazepines, so and then slowly taper them off. Benzodiazepine addiction, they'll have a similar withdrawal state, and you have to kind of taper off the benzodiazepines in that case too. With heroin, there's different approaches. With opiate addiction, there's different approaches. Some people will substitute something like methadone, which is an opiate that allows the person to live a fairly normal life, and continue taking the methadone to maintain them without. And then there's various approaches to treating opiate addiction. So our mental health assessment, or mental status assessment, as always, we're going to start with a health history. But if the person has an impaired mental status, they may not be able to give us a meaningful history, so we might need to think about other means of obtaining subjective data. You would want to explain the purpose of the exam before asking mental status questions, because otherwise they may seem threatening to the patient. They may seem silly. The person may think that you think they're crazy. They may misunderstand the reason for asking them. And so you'd want to explain that, oh, I'm going to ask you some questions that may seem silly. I'm exploring your mental function. And then you also give them permission to refuse to answer. Because, as I say, some of the questions may seem threatening or may seem offensive to the person, so certainly give them the permission to refuse to answer. And also assure them that you'll be keeping their responses confidential, and then you have to follow through. You be very careful and delicate about how you would share the results with the relatives or other people. Address the client's fears, because if a client has problems in this area, they probably, for example, an older adult who fears that he or she is getting Alzheimer's disease, you need to, if you pick up that they are having some fears related to this area, why address that. And then also pay attention to culture, where clients may prefer to have a physical disorder, so they may many times, if it seems to be a mental disorder, they'll think of, and even families, they may think of all kinds of ways that it could be due to a vitamin deficiency, or it could be due to whatever, anything but a mental disorder. Mental health problems profoundly affect self-image and self-concept, and also I would add they can affect, to get a label, a mental health diagnosis, profoundly affects your social position sometimes, where, for example, many years ago there was a vice presidential candidate who it came out that he had been treated for depression, and that was, many people felt like that profoundly influenced the election, that it caused one party to win and one party to lose. And that seems absurd today, that just because a vice presidential candidate had once sought treatment for depression, that would be a stigma that would cause another party to win. But that is how stigmatized mental health problems can be. And this was many years ago. This was maybe 50 years ago or so. So I think things have gotten better now. But even today, if a candidate, say, had had treatment for substance abuse or for bipolar disorder, that would probably be a scandal. And then the other thing, when you're doing the health history, pay attention to your own emotions, because for several reasons. One thing, as you'll learn when you get to psychiatric nursing, there's a thing called countertransference, where where the transference means that the patient is projecting things from on the nurse or the physician or on the healthcare professional. They're projecting things from their own, family background and their own pathology, where they'll see the nurse as this controlling father or controlling mother that they hate, and that they're, but that they love hate. and all this, and so all those emotions get projected onto the nurse. But there's also something called countertransference, which is an irrational reaction on the part of the nurse or physician to the patient. And so when we have these irrational emotional reactions, pay attention to them. They can be clues to what's going on in this relationship. It's a call. If you find yourself angry with a patient, that's a call to explore, like, there's really no rational reason for me to be angry. Or if you find, all these different emotions that you might feel. See, in chapter 2, we had some guidance about how to communicate with the anxious patient, with the seductive patient, with the patients that have different emotional states. And we tend to kind of, if we're not careful, we tend to get sucked into that situation. So go look in chapter 2 in box 2-3 for guidance on how to handle those kinds of situations. So for many reasons, it's usually good to start with biographical data. For one thing, it's simple data that the client should be able to answer, and this kind of provides you some insight into how oriented they are. Like if they are not able to answer questions about age, gender, those sort of things, why then they're probably not going to be able to, then that kind of tells you right off that there's a cognitive problem going on, or maybe a sensory problem. But there's some problem going on. So your simple questions are going to provide you with a baseline for how communicative and how cognitively intact that patient is. When you ask about age, and then kind of assess, are they functioning at the developmental level that's appropriate for that age? And gender identity can be a tricky thing to navigate, because unless there are people with ambiguous gender. There's people that were born with one gender and then transitioned to another, the transgendered. But there are also people that are born with characteristics of one gender, but maybe chromosomal abnormalities too. So there are people with ambiguous gender. There are various situations that can occur with gender. Marital status, of course, people are either single, married, divorced, whatever they are, but that doesn't always tell you. You may need later to explore the quality of that relationship, because you'll find some couples that are married but they have a very distant, cold relationship, and other couples that are married but they're separated and living with somebody else, and all kinds of situations that can occur. And then education and also employment. Is their employment stable? Those kinds of things too come into biographical data. Then the history of the present concern. There's the most urgent concern, probably the reason that they're seeking care. But then you also want to ask about other problems that they're currently experiencing. And some people will have a lot of them. Some of the things that they could be experiencing, maybe this is kind of a short review of systems. You could ask, well, have you had any headaches, any palpitations? You might have to explain that. Any trouble sleeping, any irritability, any mood swings, any fatigue, suicidal thoughts, or thoughts of wanting to harm other people. So even though they don't necessarily present with that problem, maybe they present with a problem where they're having hallucinations or something like that. They may be experiencing these other things as well, and if you don't ask, they may not volunteer those things. Personal health history. If we're focusing on mental status, we'd want to ask about medical treatment or hospitalization for a mental health problem, but we might also be interested in physical problems that they may have been hospitalized or treated for as well. And certainly if we're doing a comprehensive assessment, we would be interested in those things. Counseling services. Have they ever received counseling, whether maybe from the high school counselor, a marriage counselor, a parole officer sometime, maybe. They may have received counseling from different people. Neurological problems, particularly things like head injuries, seizures, meningitis, encephalitis, or stroke. And then military service, because we know that in the military people do get exposed to violence. It can be very stressful. They have comprehensive health services in the military, so they could have received counseling or been diagnosed with a mental condition in the military as well. Then you'd want to ask about family history, particularly if anybody in the family had issues with anxiety, depression, schizophrenia, bipolar disorder, dementias. And then the lifestyle and health practices section is fairly long. You'd ask them to describe their typical day and what effect does the present health concern on activities of daily living. That's ADL, is activities of daily living. What about their energy level? And ask for a usual 24-hour diet and any issues with bowels. That can be, particularly with older adults. Older adults sometimes get obsessed with their bowels, but yeah, again, Freud traced a lot of problems back to toilet training. Some people have discredited what he taught, but a lot of problems stem from toilet training. So bowel patterns can be significant for mental health issues sometimes. Other lifestyle and health practice questions. Exercise. Do they do any exercise? How much? And to what effect? And then different substances, everything from alcohol, caffeine, tobacco, drugs, etc. And as well as over-the-counter or prescribed medications. Some people have this false sense of security. Well, as long as my doctor prescribes it, why, it's okay. And so you ask them, well, let me see your medications, and they have like bottles, a bunch of empty bottles of hydrocodone, and then other empty bottles of Tylenol number 3s, and maybe some oxycodone that they got from one doctor, and then some Xanax and some Valium and all this stuff. But oh no, this is medicine, it's not drugs. I hate drugs. I don't do drugs. This is medicine. Also want to ask about environmental exposures. Then religious affiliation, and that can cover a multitude of things, where person might say, I'm Hindu or I'm Lutheran or whatever they are. That doesn't, it tells you a little bit, but it doesn't tell you much, because there might be one Lutheran that's into reading the Bible all the time and in church all the time, and another Lutheran that reads astrology books and goes to church once in a while. And similarly with every other affiliation. So you'd explore the importance of religious activity. In religion, particularly in people with mental health issues, religion can be very much a two-edged sword where on the one hand it can be a source of strength and support, but on the other hand it can be a stressor or even a source of delusions where so it can certainly be either beneficial or harmful, and it's hard to say ahead of time. Uh, Many times psychiatric patients will have delusions that they are a prophet or that they're the savior or that they're God himself or herself. And then they'll have delusions that the world is coming to an end and various things like that. So I think the idea is that in religion there's not much reality testing as far as and the mental health patient has issues with reality testing even with more concrete things where most of us, for example, uh, if we spent some money on something and we were cheated, why the reality testing aspect of it, we would learn, well, this kind of offer that they're giving us is not a legitimate offer or something. But when it comes to religion, why there's not an easy way to do reality testing even for us. And for a person that has mental health issues and maybe that they repeatedly get taken advantage of, say in a financial scam, where they could presumably they could do reality testing, and so when they get into a religious type of ideation they can just go wild, their imagination can go wild. So I think that's one of the reasons that religion can be such a tricky minefield with the mental health patient. Then you want to ask them also about how they feel about their relationships with others, both with family members, mother, father, with spouse or intimate partner, or whoever they're involved with. And that will probably involve exploration of what their relationships are like. And as you can imagine, in many mentally ill people or people with cognitive problems, then they may have very chaotic relationships, or so it may take a little bit of exploration to track down what relationships they're involved in. Then, of course, closely related to that, support systems. Who is helping this person, or are they responsible for the care of others? What role do they have in their family or in their relationship? And what stressors are they having in their lives right now? How do they feel about the future, and do they have any thoughts about hurting themselves? So then after that, doing the subjective assessment, why we'll do a physical exam. And this could be part of a comprehensive neurological assessment, or it may be a briefer, more focused assessment. Assessing mental status at the beginning of an exam will help you to evaluate, or toward the beginning will help you to evaluate how valid the subjective data is, whether you need to get subjective data from some other source. The equipment you need for the physical exam is primarily just a pencil, paper, pen, various screening tools that you might have the person fill out, or you might question them and fill out. And one thing, the first thing to assess, or one of the first things, is sensory ability, and particularly in the older client. because if you have somebody that say has a hearing problem but they kind of are good at faking it, why they may respond to what they think you're asking about and give you responses that sound like a confused person. So you may mistake this person is confused, and it may be just that he or she has problems with hearing. So to some extent this can occur with vision as well. Level of consciousness, you'd want to know, there's several things that go into it. First, alertness, how alert are they? And then also how responsive are they, able to answer your questions fluently? Do they know who they are, where they are, what day of the week it is? Do they know the situation that they're in the hospital, what place they are at, that sort of thing. If the person doesn't respond, maybe you have a person that doesn't respond verbally, so then you would use stronger stimuli, like maybe you would, yell, not yell at them, but kind of speak louder. Maybe even use a little painful stimuli and see if they respond to that. The Glasgow Coma Scale, which we'll be looking at in lab, is especially for people with traumatic brain injury, but most hospitals will include the Glasgow Coma Scale as part of your assessment for everybody. Now, if the person answers your questions, you're not going to go through all of this painful stimuli and all that. If the person is fluent in answering your questions, you wouldn't do the complete thing, but you would give them a Glasgow Coma Scale score. Other things in the physical exam are posture, gait, and movements. And then also behavior and affect. Affect means the emotional expression that they have. Dress and grooming, but you have to be careful not to make premature judgments. Because some dress particularly could be due to the culture and the person's lifestyle. Like someone that works, for example, a businessman that runs a really edgy, trendy nightclub in Deep Ellum, and that person might come in jeans and looking like with tattoos and piercings and all that, and you're thinking, this guy doesn't look like he's really, this guy kind of looks like he's not really a very high profile person. And then you learn, oh, this guy owns a $1 million nightclub in Deep Ellum, and but since he moves in that world, why he would not be dressing in a suit and tie, although maybe on occasions maybe he would. Also look at hygiene, and so does the person appear to be taking care of herself or himself. Facial expressions and listening to speech. Is the speech fluent? Is it slurred? What is the speech like? Mood, feelings, and expressions. Those are kind of, in a way they're subjective to pick up, but you can objectively distinguish between, say, a depressed mood and an elated mood. It's just hard to put it into words to describe it, but I think we know when we kind of pick up right away when somebody is depressed and expressing depressed affect. Thought processes and perceptions. Then also orientation, that's do you know where you are, who you are, what time it is, those things. Concentration, and then recent memory, we could ask something that they would have presumably seen recently, like if you know the person and you know what you might say, if it's your classmate, you might say, well, what did the instructor talk about this morning in class? So that would be recent memory. Remote memory would be something, a shared experience, but one of the tricky things there is something like if you ask what happened on 9/11 2001, why, that's been repeated in the news media so much that it wouldn't necessarily be remote memory, but there are shared experiences like that. If maybe you, for remote memory, it's helpful if you have something from the relatives, say from the wife or husband, like you could ask them, well, which college did the patient attend? And you could ask something like that. Or what year did they marry? Or did they graduate? Or things like that. Ability to learn new information. When you do the slums test in lab, you'll use that. You'll have the person learn some words and then repeat them back in a few minutes later. Then abstract reasoning, you would ask them maybe to compare and contrast, like how are tomatoes and apples and oranges similar? Or you might like ask them things like that, or to explain a proverb like what does a stitch in time saves 9 mean? Then judgment, you could ask them what they would do if they were presented with a problem. Like, what would you do if your car broke down? What would you do? Well, there's many different things that would exhibit that the judgment was intact. Like they could say, well, I'd call for a ride, or I'd get a taxi, or I would try to find a repair shop, or whatever, something that is exhibiting judgment. But if they said, well, I'd break the windows on it, or something like that, then that would not be judgment. There would be a judgment problem there. Visual, perceptual, and constructional ability, you'll be doing that also in lab. When you do the slums, you'll have them drawing a clock and that sort of thing. So this brings us to the topic of dementia. And dementia is usually slow onset, although sometimes it can be rapid onset. But it's a loss of cognitive functioning that interferes with daily life. The main thing you have to distinguish dementia from is delirium. Delirium also is a problem with cognitive functioning that interferes with daily life, but it's usually rapid onset. And both dementia and delirium will have a physiological cause, but in dementia it's usually a more permanent problem, such as maybe the vascular insufficiency, or in Alzheimer's it's unknown, but it's thought to be vascular, where delirium is going to be maybe a chemical imbalance, like say an intoxication, or some sort of a high fever, something like that, where it's not a permanent structural thing. There's two main types of dementia. There's Alzheimer's dementia and vascular dementia. That shouldn't be edema, that should be vascular dementia. And then there's also the normal changes of age. Box 6.1 in the text, and then later on table 6.1 will help you distinguish between all these different things. There are other types. For example, you may have dementia just from as a result of prolonged substance abuse, like whether it be alcohol abuse or drugs as well. Like you may have dementia that is a result of that as well. In delirium, the changes in orientation and changes in mental status are likely to fluctuate more rapidly than and more dramatically when with dementia. If you think about what causes delirium, say maybe one thing that might cause delirium is an elevated ammonia level, and that would be from liver problems. So if as the ammonia level goes up and down, then the patient will have periods where they're just perfectly lucid and you think, oh, there's nothing wrong with her at all, and then you come back several hours later and she's confused. That's not typically going to happen with dementia, at least not as dramatically, because the underlying causes are more structural. So they're not going to be just fluctuating from better to worse like that. Delirium, we assess for dementia. We assess that with. We'll see what tools we use that for dementia in a minute, in a couple slides. But delirium we assess using the confusion assessment method, the CAM tool. That's the most popular tool for assessing delirium. So Alzheimer's disease is one form of dementia. Some of the risk factors that we know of, or one of the main ones, is age. With age it increases. Genetic predisposition, if your family had Alzheimer's, why, you're more likely to. A mild cognitive impairment early on is a risk factor for Alzheimer's as well. And then Hispanic or African American ethnicity, the rates are a little higher. Any diseases that affect the vascular system, such as diabetes, coronary artery disease, cardio, things like that. High cholesterol, high triglycerides, those kind of things. Head trauma, smoking, hormone therapy, and surprisingly fewer years of education. People with fewer years will have higher rates of Alzheimer's. And poor weight control or lack of exercise. So the recommendations are kind of to avoid those things as much as possible. And even if you are diagnosed with Alzheimer's, the idea is that you can slow the progression. You're not going to stop the progression, but you can slow the progression by doing the right things, which are exercise, good nutrition, and do cognitive exercises, like have the person do crossword puzzles, Sudoku, maybe try to learn some new skills, keep their mind as active as possible as long as possible, and keep them involved socially. It's very important to try to maintain social activity for an Alzheimer's patient. Control weight, avoid any kind of head trauma. They should prevent falls and protect the head. Follow a healthy heart diet, and be very cautious about hormonal therapy. These are some of the tools that the textbook mentions for alcohol and drug screening. The only ones that are given in full there are the CAGE and the audit, and you'll be using the CAGE in your lab on each other. The CAGE is a good 4-question. I mean, it's pretty quick and easy, and it's 4 questions to screen for people at risk for alcohol problems. These are some of the screening tools for depression and for suicide risks. I want to call your attention to the sad persons one. That's like a mnemonic, and it's just things to think about when somebody, if you want to assess the person's risk of suicide, like sex, meaning gender, age, depression, if they have a history of depression, if they have a previous attempt or not, E for ethanol abuse, alcohol abuse, R for rational thinking loss, social supports lacking, do they have an organized plan, N for no spouse, and S for sickness. So each of those will be a risk factor for suicide risk. Then the geriatric depression scale is a 30 question scale. Higher numbers mean more likelihood that the person will be depressed. And I think that's given in, it's not given in this chapter 30, in the chapter 6, but it is given later in the older adults chapter of the text. For mental status, the slums, you're going to be using that in lab, and then the Glasgow Coma scale, you'll be using that in the, we'll have you assess that during your mental health assessment in lab, but more importantly, you'll be using that, I'm sure you'll be using that in your clinical for foundations, because most all the hospitals are including that as part of their charting. So after we've collected all this data, we turn to analysis and we cluster it, of course, and then we get to nursing diagnoses. And we might have some health promotion diagnoses, like we might have readiness for enhanced health management related to something, readiness for coping related to something. Risk diagnoses, we might have risk for, say, self-directed violence, or actually for other directed violence too. Risk for developmental delay, risk for powerlessness, and these would all be related to something. Remember, your health promotion diagnoses and your risk diagnosis, they have related to, but they don't have as manifested by. That's one way to recognize them when you see them written. Actual diagnoses, you might have anxiety, impaired verbal communication, confusion, and that could be acute or chronic. Acute confusion is going to point more toward delirium. Chronic is going to point more toward dementia, but there's a little bit of overlap there. So you can't use that as a hard and fast rule. Impaired memory, self-care deficit, disturbed thought processes, and social isolation. And they're going to be related to something, and they're also going to be as manifested by something else. And finally, we will have collaborative problems, and some of these might be referrals, where a collaborative problem would probably be one that would be identified first by the other healthcare provider. Like maybe the patient was admitted for stroke, and your collaborative problem is risk for complications of stroke, but you're not identifying it. Now the other thing where it would be a referral would be, and a kind of an emergent referral would be, you've got this patient and then you think they had a stroke right in front of you. So then that would be an emergency situation. You would need to refer that to a physician right away. And you wouldn't even wait to be calling a physician. You'd be calling a code stroke or whatever the hospital policy was. I mean, you'd be calling a stroke team to come and evaluate that patient and get the stroke protocol started. Another collaborative problem might be risk for complications of increased intracranial pressure. So remembering from anatomy class and from your patho class that the brain is in an enclosed space where it's enclosed in the skull, and if volume increases at all, the pressure is going to increase, and that will lead to brain damage. So anything that increases volume in the brain is going to be, like, for example, there are tumors that are benign tumors, meaning that they're not they aren't metastatic. They just are tumors that would not really cause much of a problem anywhere else. But if they occur in the brain, they can be fatal. They can kill you rapidly because of the pressure. And similarly, bleeding, any kind of bleeding in the brain is going to cause pressure. Or even a blockage in the flow of cerebrospinal fluid can cause increased pressure. So various situations can cause increased pressure in the increased intracerebral pressure. And nursing care there's specific nursing care to help minimize any increase in intracranial pressure and to help treat the problem. But it's a collaborative thing. It will involve a neurologist, maybe a neurosurgeon, various other disciplines as well. Risk of complications for seizures. That's a big big aspect of care. And that could be just about anybody. I mean, that wouldn't necessarily even be a neuro patient. It might be somebody that came in for gallbladder surgery or something, and she just happens to have a history of seizures. Risk of complications for meningitis and risk of complications for depression. Thank you.